going back in time, it was initially unclear whether multiple sclerosis was indeed a disorder that could start in childhood. Over the last 15 years, it's becoming accepted and now internationally recognized that MS is indeed a disorder that spans the age group, and that we see patients as young as 6 or 5 with pediatric onset multiple sclerosis. In children, MS is relapsing remitting in its clinical course, and children tend to have higher relapse frequencies compared to adults. So it is a very inflammatory, early onset MS form. Pediatric onset MS is a rare disease. So clinical trials in rare disorder groups are challenged by patient numbers and the need, of course, to have many centers collaborate in order to complete a trial. But we're excited that the first ever pediatric MS clinical trial has indeed completed. The results have been presented and show an 82% reduction in relapses in patients treated with fingolimod compared to interferon beta-1a by intramuscular injection. So as a community, it is extremely exciting to see both a clinical trial come to fruition. We can do this, and we did it well. To see that the therapy that was being studied was highly effective. And of course, exciting for families because this is an oral therapy. And children are not particularly excited about needles. I think the pediatric onset MS, of course, occurs in childhood by definition, and under the sort of umbrella of parent making the main decision. And with that in mind, safety, as it always should be, has been paramount in how we think about treatment. The current frontline therapies, the interferon and glatiramer acetate preparations, have been shown to be very safe over now 15 years or more. And so they've been the first-line treatment. Having said that, therapies like fingolimod or even more powerful therapies, for example, such as ocrelizumab or natalizumab and others, may have a particularly important role to play in a pediatric onset population who have such a high disease burden so early. And that would flip the way we think about caring for children. It would change from starting with lower potency agents and escalating in the context of failure to suppress to potentially starting with higher potency agents earlier to control disease early, and then maybe moving to lower potency or different maintenance agents after the disease has been in hopefully complete clinical remission. And there's a lot of conversation about which approach makes more sense and based on what evidence. In terms of the evidence that early effective therapy alters disease, several comments that I can make at this stage. So in the first ever clinical trial, there was a 53% reduction in new and new enlarging T2 lesions in the fingolimod arm compared to interferon beta-1a. So in that one first study, we can show that a medication that had a very dramatic effect on clinical relapses also had a very powerful effect on MRI evidence of disease activity. Fingolimod also reduced the rate of brain volume loss, although both groups still showed brain atrophy. So I think it's a positive first step of evidence. The real question we all want to know is if we use highly effective therapies as early as is feasible and when the diagnosis is secure, will we change how these patients experience their disease 20 years from now? Right. And we don't have that data yet. In adults, early disease control, fewer relapses early in the disease, and fewer lesions on MRI over time have associated with better outcomes. So we would be optimistic that if we then extrapolate that to a population who have even more inflammatory disease burden, that we would gain that benefit or more. But that data is going to take some years to officially acquire. I guess one comment that I would make is as we become availed of increasingly powerful medications, many of which have safety monitoring that is required or first dose effect safety requirements, and as we think about a pediatric population, we may be very effectively reducing MS disease activity, but an absolutely essential thing that we need to do as a community is long-term safety surveillance. We need to follow all of these patients carefully, and that's going to require a commitment from families and the kids themselves to be gracious and hopefully allow us to follow them carefully, but also from pediatricians, nurse practitioners, neurologists, MS specialists, all of whom are potentially going to look after these patients over the next couple of decades, and we're going to need to be a community that keeps track of how our patients are doing so that we really, really can understand the impact of the treatments we give and hopefully the benefits of the treatments we give in the long run.